I would like to introduce our esteemed speakers. Flown in all the way from Brisbane is Dr. Peter Mollee. Dr. Mollee holds many credentials, but to save time and hopefully do him justice, I will introduce him as a haematologist and director of Princess Alexandra Hospital Amyloidosis Center. Dr. Mollee is also at the forefront of systemic amyloidosis diagnosis techniques in Australia. Even more endearing is that he is married to a Kiwi, which makes him heartless. Gentlemen, the floor is yours.
Thanks very much, and thanks for inviting me over here. It's my first trip outside Australia for a long time, so I've got another 2 days with no COVID cases in Auckland, and I can get back home safely. So no COVID in here, please. Okay, so I've been asked to talk about AlAmyloidosis and AlAmyloidosis. Sorry, it's not working. I have to turn it on. Turn it on. It's a trick. Okay. Next, please. Actually, we're going to go through, we skip through a few slides because Simon talked a little bit about what amyloid was. Keep going. 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 Okay. Okay. So, just a bit of indication, how many patients have AlAmyloidosis or a carer for someone with AL? Okay. The kidneys, the liver, and the nerves are affected. Next one. So what are these light chains? I'll just spend a minute trying to explain this because it's technically a bit difficult. So light chains are part of what medically we call immunoglobulin, but what most people call antibodies. So this is what your immune system makes to fight off a virus, for example. And the way it works normally is that you get two of these heavy chains. These are proteins, heavy chain proteins. So your plasma cell makes two of these. It makes two light chains, and they assemble together to form the antibody. And what happens is at this end of the antibody is what recognises the target, so say a virus, and this end is what attaches to one of your immune cells. And so what it does is it brings your immune killing cell right next to the virus and kills it. So that's how it works normally. Next one. So your plasma cells live in the bone marrow. This is kind of what they look like down the microscope. These little cells are blue in the, called the cytoplasm. And this little whitish area is the factory where all the antibodies are actually made. Next one. So in AlAmyloidosis, these plasma cells grow into what we call a clone. They proliferate. Now each one makes normally a different type of antibody, but when you've got these proliferation of plasma cells, they're all making the same type of antibody. So they're all making this heavy chain and this light chain that forms into the antibody molecule. So it's all just one type. Next one. But what happens when your plasma cell is making these antibodies, it in fact always makes some light chains in excess to the heavy chain. So the heavy chains and the light chains join together to make this antibody, but there's always some light chains left over. And these are what we call free light chains, and there's two types, Kappa or lambda. So in AlAmyloidosis, the amyloid deposits can be made of either Kappa light chains or lambda, not both in an individual, just one type. Next one. So this is a very confusing area, but I'll try and explain the association between the type of growth of plasma cells and whether the light chain itself causes amyloid or not. Now, if you've got a cancerous proliferation, or malignant proliferation of plasma cells, it's making a light chain, but that light chain just circulates around the blood, doesn't cause any trouble at all, which is in fact most of the time. You've got multiple myeloma. If you've got a cancerous plasma cell, however, the light chain that it makes can misfold and form amyloid, then you've got multiple myeloma with AlAmyloidosis. In the more common situation, and this is in fact in about, say, 5% of 70-year-olds, very common to have a proliferation of these plasma cells, makes a light chain, it circulates around the blood, doesn't cause any trouble at all, just pee it out. This has got a particular condition, MGUS. However, if that light chain, and this is the 10 per million type of situation, it misfolds and forms amyloid, then you've got AlAmyloidosis. So you can have AlAmyloidosis and underlying the plasma cell proliferation is not cancerous, that's the more common thing, but sometimes it is cancerous and you've got myeloma. Next one. So the symptoms are very varied, and it just depends on what organs being infected. Simon's run through some of that. Next one. The presentation is often delayed. This is from our own clinic, 18 to 24 months of symptoms before someone's diagnosed. It's a problem. Maybe I won't run through these, but Simon's gone through them. Next one. There's a couple of things that happen only in AlAmyloidosis, tingling type symptoms, or the autonomic nerves. The diagnosis is based on a biopsy, so still at this time it's impossible to make a secure diagnosis without a biopsy showing amyloidosis. Once you've found amyloidosis, you must prove that that amyloid is actually made of light chains. And this is key, as Simon mentioned, to managing patients with amyloidosis. The type determines the outcome, it determines the treatment. So if you haven't got the type right, you can't get those other things right. So it's absolutely critical. And there's a number of tests you can do to try and sort that out. And this is one of our main functions, in fact, of the Amyloidosis Network, is to provide the expertise to get that diagnosis right. In the majority of cases, it's not that difficult, but in a small number of cases, it's very difficult to work out what the type of amyloid is. Next one. So I'm just going to present on the way through a couple of cases that have come to us. Here's a 69-year-old man. He was found to have kidney impairment, so his kidneys weren't working properly. He had this thing called nephrotic syndrome, which is where he's losing a lot of protein into his urine, ankles are swelling up. He also had emphysema, so lung disease, bronchiectasis, this is a chronic lung problem, a high biopsy because he had this problem, and he's found amyloid in the various bits in the renal biopsy. Next one. This is typical amyloid, it stains red, sort of a pinky orange red depending on what your microscope setup is, with this dye called Congo Red. Next one. Next one. So he had more blood work testing and he had one of these monoclonal gammopathies in the blood, so a light chain in the blood that shouldn't be there. He had immunohistochemistry and... Oh, that's on. Had immunohistochemistry, special test to try and work out the type. And you can see it says equivocal here. This is very commonly the result with these tests. They're not that good for amyloid. And so it was thought he could have AA amyloid, but maybe could it be AL because he's got a light chain circulating, or could it be one of the hereditary ones? So how could it be sorted out? Next one. So we did this test called tandem mass spectrometry, which proved in fact that he had serum, his deposits were composed of serum amyloid A2, and there's no other way to sort this issue out besides access to specialised testing. Next one. So I just thought I'd tell you quickly, just out of interest, what this technique is. So what happens when you have a tissue biopsy is that in it, it's not all amyloid, there's lots of normal structures of whatever organ that you've taken. So if you take a biopsy of the bone marrow, there might be a tiny little bit of amyloid, but lots of normal blood cells, there'll be bone, there'll be fat cells, all sorts of things in there. And the problem if you try and analyse the whole tissue is that the proteins in the amyloid get swamped by the proteins in the normal tissue. So what we do is this thing called laser capture microdissection. So This is a fancy technique where you look at the sample down a microscope and you dissect out with a laser just the amyloid deposits and leave all the rest of the tissue there. So when you've done that, this is about what you see. So here's a centimetre marker, millimetres things, and so this little thing there, that's the bit that's been dissected out. So it's pretty small, but it's much better than dissecting the whole tissue sample, which will often be, you know, this big or sometimes this big. And then you do this fancy thing where you put it through this machine. So you dissect it out. Maybe we'll just skip through all of this. Keep going. Oh, actually, sorry, I'll just show you the pictures. Go back. So this was someone that we had. This was a gallbladder, I think, and this is a Congo Red Stain without what they call the normal stain. But you can see there's amyloid here in these blood vessels. So when we cut it out, just the next one, you can see that's been chopped out, and all this other stuff, which doesn't have amyloid in it, that would normally interfere with your analysis, is gone. Next one. So all you're analysing is these little pieces of tissue, and these are like 1/10 of a millimetre in size. They're very small. Next one. Next one. Keep going. Keep going. Keep going. Keep going. So in the end, you put it through this machine, and it tells you what proteins are in that sample that you've just analysed. If you're in luck, which is about 95% of the time, it's got a pretty clear readout as to what amyloid protein is there. Next one. And just to show you about how difficult this is and how significant it is, I don't want to alarm you that people are making wrong decisions all the time, wrong diagnoses, but over the years you see a few of these things. He was a 60-year-old man who had undergone an autologous stem cell transplant. So that's pretty intensive therapy. 10 years previously for what was thought to be AlAmyloidosis. So very appropriate therapy for that. But then he relapses and his sample comes to us. He never had AlAmyloidosis. He never needed that transplant. Completely inappropriate. Another chap that came to us, only 65, so young, but he was actually having his stem cells collected to proceed to a transplant for AlAmyloidosis. And in fact, his sample came back in the midst of his stem cell collection, and of course he was transthyretin amyloidosis, completely inappropriate therapy. And so it illustrates though that it's difficult to make the diagnosis sometimes. So your doctors need to be aware of it. Next one. So the lesson is the key to correct management is to get the diagnosis right. Treatment differs according to the amyloid subtype, so you can't get it wrong. You can't get it wrong because chemotherapy and autotransplant, which are great for AlAmyloidosis, are very deleterious to other forms of amyloid. Patients with ATTR, as we've just heard, need to be treated with transthyretin stabilizers or knockdown therapies, completely different types of treatment. You might need a kidney transplant for bridging amyloid, and secondary needs control of the underlying disease. So these are very significant and expensive, potentially toxic therapies. You've got to get the right one to the right person. Next one. So once you know you've got AlAmyloidosis, you need to know all about the light chain that's causing the amyloid. You need to work out whether you've got the cancerous form or not, called myeloma, that can alter things, and you need to know where the amyloid is. Next one. So that means, next one. You've got to define the light chain and the clone that's making it, and that means these tests: serum protein electrophoresis, urine protein electrophoresis, serum-free light chain bone marrow plasmacytosis. But in particular, you need to know as a patient about your serum-free light chain. When we're trying to work out if treatment is working or not, all of these things are looked at, but this is the most important one, the serum-free light chain. Next one. Myeloma is a bone cancer which causes problems in the bone where it gets weak, can fracture, there are holes in your bones, so you need some sort of test of your bone, a scan, X-ray, MRI to work out if you've got bone disease. Myeloma causes the calcium to go up, you get anemic, got high numbers of plasma cells. So all those things need to be done just to make sure you don't have myeloma. Next one. And then you have to assess which organs are involved, which this is kind of the minimal thing. To assess the heart, you need an ECG. That's where you get the dots put on your chest and you see the little thing beeping up and down, which in the movie stops. That's no good. You need an echocardiogram, and these two things, if you have AlAmyloidosis with heart involvement, you must know these numbers, BNP and troponin, because these are the things we use to work out whether the heart involvement is worsening or improving. For the kidneys involvement, you need to know, are you losing protein in the urine? And that often involves a whole day collection of urine. You need your creatinine, that's otherwise a measure of your kidney function. In your liver, it's how big your liver is, and a liver blood test called ALP. Neuropathy is really based on symptoms rather than a particular test. We do have a test, but it's not terribly good for monitoring. Some patients have problems with their blood clotting system. Next one. And sometimes you need to do other tests depending on the situation. So some patients might need an MRI of the heart or some sort of monitor of their heart rhythm, nerve conduction tests. They might need to have a look in the upper or lower bowel, just depending on what the presentation is. Next one. In terms of heart assessment, this is something that it's worth you knowing about. Traditional echocardiography, which is where you can see your heart beating on the screen, a little bit like the same technique with ultrasounds that you do to look at babies in pregnant women. So you can see your heart beating away. And there's been some innovations in that, particularly one that's called strain imaging. And if you've got heart involvement, this is TTR or AL, you should ask your cardiologist, do you have strain imaging? Because it is a far better technique. It's a quantum leap forward in terms of assessing your heart involvement. And it shows, you know, it uses a lot of fancy software, but amyloid's got a particular pattern on it, so it's very useful for diagnosing heart involvement. And there's parameters that change as treatment is working or not working that are useful. So that's something that's been developing in cardiology circles over the last 10 years. Over the next 10 years, I suspect all echo machines will have this strain imaging. Cardiac MRI is a very useful technique for diagnosing involvement of the heart, and sometimes you need that because the echo is not clear. Next one. These are these heart test markers that I mentioned to you about, this BNP and troponin, and there's a staging system based on these. And it splits people up into stage 1, 2 or 3. And you can see if you've got stage 1 disease, that is almost no heart involvement or no heart involvement. People here out at 60 months, so 5 years, pretty much everyone's alive with AlAmyloidosis. Whereas if you've got advanced heart involvement, this down here, at 5 years, only about 25% of patients are alive. So having heart involvement in AlAmyloidosis is a very important predictor of how you're going to go. And to get that information, you need these markers, BNP and troponin. Next one. Here's a test we've been working on in Brisbane for a few years where we've been looking at PET scanning using things that are used in Alzheimer's disease. This Alzheimer's disease has got amyloid plaques in it, completely unrelated to these systemic forms of amyloidosis, not related in any way, but the structure of the material is similar. And so these things which bind to amyloid in dementia plaques in Alzheimer's disease, in fact, bind really well to amyloid elsewhere. And so you can see here in someone with AL amyloid, this is the heart here, you can see it lights up nicely. Transthyretin amyloid lights up easily. These were patients with severe hypertension. The heart doesn't light up at all. So it sort of looks like it might turn out to be a useful test. Next one. So how can we treat amyloidosis? This is a little bit similar to what Simon put up. You can do something to reduce the supply of the amyloid-forming protein. You can do something to try and stabilise the light chain-forming protein in the blood so it can't misfold. Or you can do something to try and get the amyloid out of the tissues. Next slide. So first, and this is still the only standard therapy proven in AL amyloidosis, you can give chemotherapy to kill the cells in the bone marrow that are making the light chain and thereby bring the light chain down. Next one. So the treatment principles in AL amyloidosis is to reduce this monoclonal production as protein production as profoundly and as quickly as you can. You want to aim for what they call a complete or very good partial response. There's definitions of this, but you want to get that light chain down as far as you can, hopefully gone completely, and as quickly as possible. It's not that straightforward, however, because you have to tailor the therapy to the individual. And this relates to a couple of things. The treatments have different side effects, and so you can't use every treatment in every person. There are some drugs you can't use if the liver or kidneys are not working properly. It depends on the extent and degree of organ involvement. If you've got advanced heart involvement, it's too dangerous to do a transplant, for example. And a big issue for you in New Zealand and for us in Australia is availability of drugs. So you might hear all these things are useful, but you can't get hold of them unless you pay for it yourself, and that can be prohibitively expensive. And the other principle of treatment is you need organ-specific supportive care. Next one. So AlAmyloidosis, there's no doubt now that the mainstay of treatment of this drug called bautism, otherwise known as Velcade, commonly use these three drugs together: Velcade, cyclophosphamide, and dexamethasone. If you go to Canada, they call it Cyborg-D, cyclophosphamide, bautism, dexamethasone. Or if you go to the UK, they call it CVD, cyclophosphamide. But we like to mix the initials around to make sure that no one knows what we're talking about. Some places use melphalan instead of cyclophosphamide, but it is based around this drug, bautism. Transplantation is being used less and less, I think, as time goes by because of the greater efficacy of some of these other treatments, but still can be useful. And there's lots of other drugs. These are drugs that we can access in Australia. New Zealand was the first country in the world, and still one of the only, where bautism is actually approved for AlAmyloidosis. They sort of got it through Dr. Goodman, in fact, which got appended to a myeloma application for bautism. So he added in the words "and AlAmyloidosis," and it stuck through Pharmac. No other country in the world had that approved until just recently in the US when they got Velcade approved. So in Australia, we can't access, we have no drug approved for amyloidosis. We can only access it by saying every patient has myeloma. So every AL patient of mine with amyloidosis has myeloma, even though they don't really have it. That's the only way to get the drugs. So all of these are in Australia, and some of them in New Zealand approved for myeloma. And you just get what you can get access to. But the point here is, I guess there are multiple options. There are a number of things you can cycle patients through if the initial treatment doesn't work. Next one. So we participated in this trial. There's a collaboration between us and the Europeans to look at whether bortezomib really works or not. Next one. This was a trial where half of the patient got the traditional treatment, which 12 years ago used to be melphalan and dexamethasone, two common drugs, and the other half got bautism as well. And this is a graph of how many people are alive, and you can see the red line, those that got bautism, more patients alive than those that didn't. And so bautism is, on the basis of this study, the standard treatment for upfront of AlAmyloidosis. Next one. This trial's just recently been published, which was looking at a new drug called daratumumab, an antibody against something on the surface of plasma cells, very good at killing it. And it looked at Velcade-based treatment with or without that daratumumab. So half the patients got just the 6 months of Velcade-based treatment, half got the same treatment but with daratumumab on top. Next one. And this was certainly very exciting results, but as of currently, only approved in the US in the world in terms of regulatory approval. Probably not in Australia for a couple of years, I imagine, but we'll see how we go. New Zealand, I don't know. But this is how many patients achieved a complete response. That is, you could not detect the light chain at all on our current testing. This is what you want to achieve. And you can see it went from 19% to 59%. So very good at getting rid of the light chain. But what you want in amyloidosis is not just to get the light chain down, you want to get the organs better. Next slide. And this trial was very pleasing. This is 6 months follow-up, and this was 12 months follow-up. That essentially I've got telling you the wrong thing. This is heart at 12 months follow-up, and this is kidney. So if you have the daratumumab, the purple bar, basically double the improvement in kidney involvement, double the improvement in cardiac involvement if you get the daratumumab. So there's no doubt that the combination of bortezomib with this new drug daratumumab will become the standard treatment. It is now in the US, and I guess as it gets through the regulatory processes, it will be in other places in the world. Next one. Auto-transplantation, I won't say too much about it. This is a way to deliver a very high dose of chemotherapy to try and completely wipe out the clone. It's got good response rates, although its response rates are not as good as in the trial I just showed you. So it'll be used less and less, I think. But there is lots of long-term outcome data. It's been used for a long time. It's still got a role in patients. Next one. Next one. The last thing I'll just talk about is immunotherapy. Next slide. So there's previously been attempts at trying to get amyloid out of the tissues quickly. Because that's what's causing people to be unwell and have symptoms. And in the case of amyloid in your heart, that's what's life-threatening. Particularly in AlAmyloidosis, where the cardiac involvement is so much more dramatic than in transthyretin. It moves much more quickly. So what you'd like to do is just get that protein out fast. And the problem is your immune system does not recognise it very well. Your immune system should be able to get rid of foreign protein, but perhaps because it's your own protein that's misfolded, it doesn't recognise it very well. So this is an antibody which has been designed to bind onto amyloid in the tissues, but not onto the circulating light chain or the plasma cells, and tell your immune system, here's the amyloid, come and eat it up. Next one. So this trial has just started around the world, and half the patients will get that VCD chemotherapy, and half the patients will get that with this new antibody to see if it really does bring the amyloid out more quickly. This drug, antibody, has been shown to be safe. It's been given to a number of amyloid patients without side effects, and it's got some hints of working. It certainly works well in a mouse in a test tube, but whether it really works in patients with amyloidosis, this trial will tell us. Next one. So this is kind of, Simon and I wrote these guidelines for Australia. This is kind of our approach. Everyone starts with bortezomib-based treatment, but what happens depends on how good the response is in bringing down those light chains. So I'll just show a couple of things. If your response is really good, what they call a complete response, we can't detect the light chain at all we do is finish off that chemotherapy treatment with that Velcade, nothing more. On the other hand, if it is not coming down enough after 2 or 3 cycles, you don't stay on the treatment for 6 months, you switch. You've got to find something that works, that brings the light chains down. Because if the light chains don't come down, that amyloid is not going to have a chance to come out of the organs. So you don't want to be staying on ineffective therapy. Next one. Just a couple of words on monitoring, and then I'll finish up. So you have to monitor the progress with assessments of the amyloid-forming free light chain, which could be Kappa or lambda, depending on what you've got. You've got to measure these cardiac biomarkers because of all the organs that can be involved. The heart's the most critical, so you certainly want to know about that. If the light chains are coming down, the treatment's working, you want about a 90% reduction. There are strict definitions about these things, which I won't go into, but you want to see it coming down a lot. We've certainly got far more options than 5 years ago. The treatment field has really changed a lot. It's improved. Next slide. Besides the light chain, you'll want to also be having measurements of your organ function. So that can include these biomarkers, but an echo every now and again, urine tests and blood tests for the kidneys, liver tests and feeling the liver or a scan for your liver, nerves based on symptoms. Next one. Yeah, just keep going. I think we'll... do you want me to talk about secondary amyloid? There's no one here with it, so... Or online, I guess maybe there could be. So maybe I'll just quickly go through secondary amyloid. Next one. I've got a few slides. So it used to be called secondary amyloid, now it's AlAmyloidosis because the protein is serum amyloid A protein. Next one. So these are amyloid fibrils that derive from the serum amyloid protein, which is produced when your body has inflammation. And inflammation can be due to an inflammatory arthritis, it could be an inherited problem, it could be inflammation due to a slow-growing cancer or a chronic infection. So in fact, the inflammation has to be going for a long time. In fact, in the UK series, an average of 17 years of some sort of inflammatory disease before patients develop amyloidosis of this type. Nearly always involves the kidneys, which causes loss of protein in the kidneys. Kidneys don't work as well. Less common in the liver, the adrenal glands, very uncommon to be in the heart, extremely uncommon to affect the nerves. Next one. Next one. So these are the diseases that patients can have that are causing the production of this long-term elevated serum amyloid A protein. So rheumatoid arthritis, very common underlying cause. It's becoming really uncommon in the Western world, secondary amyloidosis, because control of arthritis and control of chronic infections are problems of the third world now. The treatments we've got in the West for both of those things are very good. So, in fact, what we do see is we see problems with intravenous drug users who get chronic infections in their skin from where talc and stuff that they've been injecting just causes chronic lumps and infection. We've got 2 of these in our clinic. Tuberculosis, I mean, we just don't see that, but in some parts of the world it's still very common. There's some inherited problems where you get high inflammation all the time. It's uncommon to have these other sort of chronic infections. So it's becoming very uncommon of all the amyloids, but it's still around. Next one. Next one. So what do you do about it? In fact, you have to treat the underlying disease. And if you can reduce this serum amyloid A protein down to low levels, or if you can't measure it, because a lot of places don't have that test, you can measure a much more common test that's available in every laboratory called the C-reactive protein. You get that down as low as possible, and as with every type of amyloid, and demonstrated recently by patisiran, if you can get the amyloid-forming protein down low enough, you can actually get stabilisation, you can get improvement with amyloid coming out of the tissues. And the same is with AA amyloidosis. There is a drug that's been developed to interfere with deposition of the fibrils, and the initial trial showed some slowing of renal deterioration, but didn't prevent patients progressing to needing dialysis, so not that effective, and supportive care is very important. Next one. So I think that might be it.